Hey everyone, welcome back to Static Cardiology here on EMTV. I'll be giving you an ECG rhythm and a scenario. On the bottom of the screen you'll see a timer for 1 minute and 30 seconds. This time is there because if you're taking the National Registry exam, 90 seconds is about the average amount of time you'll want to take on each card during the Static Cardiology test. When the time is up, we'll do a walkthrough where I'll give you my answer as well as my treatment. Enjoy the card, and good luck.
3, 2, 1.
To identify this rhythm, we'll look at the bottom lead 2 in a little bit closer detail. Now remember, when you're looking at a 12 lead, this is a 10-second strip. So unless your math is really good, we're going to go ahead and cut this into a 6-second strip. So the way I do that is I take 2 lead groupings, and remember each one of these lead groupings represents 2.5 seconds of time, and then I'll add 5 big boxes to add 1 more second. Now I'll go ahead and count the R waves to get a rough idea of rate. So I'm getting a heart rate of about 50 BPM. Next thing I'll look for is my R to R consistency. The R to R interval here looks pretty consistent, so this is a regular rhythm. I'll check my PR interval next. My PR interval here looks pretty normal, and it looks like it's fixed, meaning there's no lengthening or shortening of that PR interval. As I'm continuing to look at the strip, I'm noticing some irregularities in the T waves. The notches that are present here are not actually an abnormality in the T wave. This is a P wave, meaning that I have extra P waves for QRS complexes. As a general rule of thumb, if you have extra P waves for QRS complexes, you're looking at some type of AV block. Now, because there are drops in QRS complex, the PR interval stays consistent and is less than 0.2, the only AV block this can be is a second degree type 2, or a Mobitz 2 block. Because we're looking at a 12 lead, let's go ahead and take a look at the other lead groupings now to see if there's anything more malignant going on. In the anterior lead grouping, I'm not seeing anything concerning apart from those extra P waves that we had mentioned before. You'll notice that in some leads, they're far more evident than in others. But because this is a 12 lead, we know that if the extra waves are existing in one lead, they must be existing in others as well. Let's go ahead and take a look at the inferior leads next. Once again, in our inferior leads, we see evidence of those extra P waves. Finally, we'll move on to the lateral leads. In our lateral leads, more extra Ps and dropped QRSs. Now that we've identified the rhythm, let's go ahead and take a look at the scenario to determine whether or not this patient is stable or unstable. You were dispatched to a public park for a 77-year-old female who has fallen. Upon arrival, you find your patient laying on the ground, responsive only to painful stimuli. The patient's airway is patent, peripheral pulses are weak, and there are no external signs of trauma. Your partner obtains the following vital signs: blood pressure 74/40, pulse 50, respirations 21, SpO2 93% on room air, and a blood sugar of 106. You attach the monitor and obtain the ECG above. So in order to be successful at the static cardiology station, you must perform the correct treatment on your patient. Correct treatment comes down to determining whether or not your patient is stable or unstable and following that algorithm. For determining instability, I use the acronym CHAD. And this, of course, stands for cardiac insufficiency, hypotension, alteration in mental status, and dyspnea. Based on this patient's current presentation, their vital signs, and the history provided, my final diagnosis for static cardiology is an unstable second-degree type 2 AV block. Now, let's go ahead and move on to treatment. I'll begin treatment by regurgitating the mantra, Scene Safe BSI IV O2 monitor. Because this patient is bradycardic, I'll then consider administering atropine 1 mg IV push. But be aware that the high degree of block that this patient is experiencing implies significant damage to their AV node. For atropine to be effective, a functioning AV node must be present, so don't expect the atropine to be as effective as you'd like it to be. But due to this patient's instability, transcutaneous pacing is going to be the most definitive treatment. As my patient is conscious, I'll consider sedation, and you can use a number of drugs to accomplish this. I'll then attach the pads and turn on the pacer function of my monitor. I'll select a rate, anywhere between 60 and 100 ppm, and then I'll increase my milliamperage until I achieve electrical capture, and I'll confirm a carotid pulse, checking mechanical capture. For additional pressure and rate control, I could then consider administering a vasopressor like dopamine or epinephrine infusions. And finally, rapid transport. And that's it. If you like this card, please make sure to head over to my channel for more. And while you're there, check out my other playlists, Static Pharmacology, as well as Paramedic Pathophys. Once again, thank you so much for watching and supporting the channel. Until I see you next time, have a good rest of your night and keep washing your hands.